Welcome. My name is Mark Farber, and I am the director of the UNC Aortic Center. I'm going to talk to you a little bit about the management of aortic disease in 2011. As many of you know, over the past decade and a half, the operative mortality for treating patients with aneurysmal disease has decreased by using minimally invasive techniques called endovascular aortic repair, or EVAR. Those reductions in mortality are seen the greatest in patients that are the oldest. In addition, we've also made a significant improvement in mortality of patients that undergo aortic ruptured repair by using the minimally invasive techniques. At UNC, currently we have numerous devices available at our hospital to treat any patient that arrives with an aortic emergency without having to do open aortic repairs. By doing so, we've seen an increased number of patients with complex aortic problems. However, with minimally invasive aortic repair, despite the fact that the complexity is increasing, the number of complications that we experience are still remain very low compared to open repair by using these minimally invasive techniques. Extensive aortic involvement not only involves patients with disease below the renal arteries, but all the way up their aorta to their thoracic region by the great vessels. What's driven this entire treatment modality has been the advancements in minimally invasive imaging. Detailed CT scans, as you see here, can show us every vessel that the patient has, its exact location and orientation off the aorta. By using this advanced imaging in conjunction with minimally invasive techniques, no longer do we have to treat patients in this fashion, which is an open thoracoabdominal aneurysm repair, and has a significant impact on the patient's overall physiology. By using fenestrated concepts, which are holes or spaces in the device, those spaces can be used to allow perfusion of blood flow to the branch vessels of your aorta, and then we cover those areas with an extension into the vessel with what's called a stent or cover stent to maintain that blood flow after the repair. This is one of those such patients that we treated in one of our recent trials, and here you see both the renal arteries and the superior mesenteric artery and celiac artery are impacted by the device. Here is a similar patient now 3 years after that type of repair, and you notice in the purple there that the aortic aneurysm has shrunk over time and is no longer as big as it started. This is what we're after, reducing the pressure on the aortic wall and actually preventing rupture of these aneurysms. Not only have we seen patients with aneurysmal disease being treated, but we've now extended this therapy beyond patients with aneurysms to those with dissections, transections, ruptured pathologies, and penetrating atherosclerotic ulcers. By doing so, those patients that once had to go significant open repairs can now all be treated with minimally invasive techniques. This is one such patient that has already had a coarctation repair and now has a large pseudoaneurysm up in his left chest. By using a single groin incision, we can cover that pseudoaneurysm up and maintain blood flow to the great vessels without causing major surgery in these types of individuals. We can also combine these fenestrated techniques with branch techniques, which come off the main device and then also feed the vessels. This patient here, as you see, has had both branches to the superior mesenteric and celiac artery, as well as fenestrations to both renal arteries, which maintain perfusion after the repair. In conclusion, through advanced aortic techniques, almost all patients can be treated with minimally invasive techniques. By doing so, major complications can be reduced. Patients who were once deemed inoperable in the past are now able to receive advanced aortic care. I invite you to join with us in treating your patients in these minimally invasive techniques and advancing the care of patients with aortic disease. Thank you.